All right, guys, so this chapter is going to cover, or this podcast is going to cover chapter 14, which is going to be the whole discussion of the heart. So lots of information here. I'm going to help to try to, differentiate, the importance of things here, but there's just a ton of information. So you're going to have to really spend some time. The heart is kind of the engine of life, right? We need to have the heart functioning in order to survive. Beats approximately 100,000 times in one day. It works constantly to deliver oxygen-rich blood to our organs and tissues and to return oxygen-poor blood to the lungs to get rid of waste products like carbon dioxide and reoxygenate. So lots of things happening. First, we should know where the heart is located. Okay, it's about the size of a fist. Heart lies in the thoracic cavity in the mediastinum, so between the lungs and underneath the sternum. The heart tilts a little bit towards the left, so 2/3 of it extends to the left of the body's midline. The broadest part of the heart is the base. It's at the upper right, and the pointed end, the apex, is at the left, the lower left, okay? The point of maximum impulse, or where we can actually maybe feel the strongest heartbeat or hear it, the apical pulse we call it, is located at the apex. So that'll be someplace you guys will have to find. Okay, the great vessels enter and leave the heart at the base. And cardiology is really the study of the heart and the treatment of cardiac diseases. So cardiology or cardiologists are specialty doctors that people will see when they need treatment for heart conditions. So let's start with some anatomy and talk about heart structures. So we have multiple membranes around the heart. First, we have a double wall sac called the pericardium. It surrounds the heart and is anchored to surrounding structures by ligaments and tissues. Then the pericardium has two layers. The outermost is the fibrous pericardium, a loose-fitting sac. And then we have the serous pericardium, which covers the heart's surface. Break that down a little bit farther here. Okay, remember that we talked about serous membranes, and they all have two layers. So at the heart's base, it kind of folds back on itself. We talked about this happening in the lungs, but it does also happen here. We have the parietal layer, which is kind of the outside portion, lines the inside of the fibrous pericardium, and then the visceral layer, which actually covers the heart surface. Okay, the pericardial cavity is in between these two layers, and it contains a very small amount of serous fluid, which helps prevent friction when the heart beats. The heart wall itself has three layers. The endocardium lines the chambers, covers the valves, and continues to the vessels. Consists of a thin layer. The myocardium is really the cardiac muscle, so it forms the middle layer, and it's the thickest of the layers and performs the work of the heart. And the epicardium consists of a thin layer of squamous epithelial cells and really covers the heart's surface. It's really the visceral layer of the serous pericardium. So you'll have to memorize those layers, the parietal and the visceral layer, okay? And then you have the fibrous layer on the outside, and then you have the three layers of the heart wall. Multiple chambers in the heart, okay? So there's 4 chambers. They're hollow chambers, so they allow blood to be pumped into them. We have the atria, or atrium is singular for the upper chambers, and then the ventricles are the lower chambers. The atria serve as reservoirs. They receive blood from the body or the lungs, and they're separated by the interatrial septum. The walls of the atrium are not as thick as the walls of the ventricles because the atrium move blood only a short distance. So they only have to move the blood from the atrium to the ventricles. The ventricles then receive this blood and pump it to the lungs, the right ventricle, or the body, the left ventricle, and they're separated by the interventricular septum. Because the ventricles pump blood, they must generate more force than the atria, and therefore their walls are thicker. Because the left ventricle itself must generate force to push blood throughout the body, its walls are the thickest. So the left ventricle there is going to be the largest ventricle, and it's going to have the most ability to produce force. The great vessels, the superior and inferior vena cava, the pulmonary artery, the 4 pulmonary veins in the aorta transport blood to and from the heart. So you can see all those great vessels there sitting on top of the heart. Okay, so you'll need to know all those different structures. Let's talk a little bit about the valves that allow blood to move from the atrium to the ventricle and then out to the lungs or the body. Here on the left, it's showing the ventricles relaxed, and then it's showing the ventricles contracting, and what the valves are doing during those times. So each of the 4 valves are formed by 2 or 3 flaps of tissue called leaflets. We have 2 atrioventricular valves, or AV valves, and they regulate flow between the atriums and the ventricles, right? Atrioventricular valves, that should be pretty easy. We have 2 semilunar valves, and they regulate flow between the ventricles and the great arteries. So the right AV valve, also called the tricuspid valve because it has 3 leaflets, prevents backflow from the right ventricle to the right atrium. The left AV valve, called the bicuspid valve, it only has 2 leaflets, also known as the mitral valve, prevents backflow from the left ventricle to the left atria. Okay. The semilunar valves are the pulmonary and aortic valves. The pulmonary valve prevents backflow from the pulmonary artery to the right ventricle, and the aortic valve prevents backflow from the aorta to the left ventricle. And as we get to see blood flow through the heart, this will make it a little bit more clear and hopefully make it easier for you to memorize these. Okay, so we always have 2 AV valves. Okay, mitral valve is bicuspid. Then we have the tricuspid valve over here. Then we have the aortic valve and the pulmonic valve. So this is going to push blood to the pulmonary artery, and this is going to push blood to the aorta. Aorta is going to take blood to the body. Pulmonary artery is going to take blood to the lungs. We also have the heart skeleton. Okay, it's a semi-rigid fibrous connective tissue. It encircles each valve, supports the heart, and keeps the valves from stretching. Those valves have to maintain their elasticity. It also prevents or provides insulation between the atria and ventricles. We're going to talk about electrical conduction going from the atriums to the ventricles, and we don't want them to get confused in their pathway. So this provides some insulation and makes that pathway correct. The heart makes some sounds. This is what happens when the physician or nurse is listening to your chest, listening to the heart. Really, the one you need to know is the apical pulse. Okay, that's down at spot number 4. You find it by going to the 5th intercostal space. So you really have to feel up at the top. Okay, you can feel the first large bone there, and you can feel a little indentation. Okay, that's your first intercostal space, and you feel them all the way down to the 5th. It can be difficult. You go to the mid-clavicular line, and this is where you're going to find the apical pulse. So you're going to hear the heartbeat the best at that position, okay? And this is where you will always count the pulse or the heart rate here for 1 minute. So again, you're using your stethoscope here, not using your fingers like you've learned to take radial pulses, but you're using your stethoscopes. You're going to find this place, you're going to listen to the heartbeat, and you should always count the apical pulse for 1 full minute. What makes these noises is the valves closing, and that's what causes the noise to be able to be heard by the stethoscope, okay? If you go on to RN school or even on to NP school or providers, when they listen in all these different areas, and they can hear different types of murmurs or valve issues in all the different areas that they listen. But you guys really just need to know that mitral area or and the 4th area there where you're going to find the apical pulse. So let's move our way on to blood flow through the heart. So this is a pretty big process, okay? So no connection exists between the right and left sides of the heart. So the 2 sides must work together to ensure that the organs and tissues of the body receive an adequate supply of oxygenated blood. That's really what the heart's job is get oxygenated blood out to the tissues and bring oxygenated blood back to the heart to go back to the lungs, okay? So both the right and left atria contract at the same time, as do the ventricles. This isn't 4 different things, contracting at separate intervals. The atriums contract first, then the ventricles contract, and they're always doing that simultaneously. Okay, so the right atrium here receives deoxygenated blood, which is why it's blue. But again, remember, blood is never blue. But if you see blood, it means it doesn't have oxygen in it in a diagram, okay? So deoxygenated blood returns from the body through the superior and inferior vena cava. Once the right atrium is full, it contracts. This forces the tricuspid valve open, and blood flows into the right ventricle. When the right ventricle is full, the tricuspid valve snaps closed to prevent blood from flowing backward into the atrium. Okay, so we get the atrium filling, pushes this valve open, blood goes into the ventricles. So a lot of it moves passively into the ventricles, and then at the end, the atriums actually contract and force any blood left over, as much blood as they can, into the ventricles. Once the ventricle is full, this valve closes again. Next, we get the right ventricle contracting, forcing the pulmonary valve open. Blood is pumped from the right and left pulmonary arteries onto the lungs, okay? After the right ventricle empties, the pulmonary valve closes to prevent the blood from flowing backward into the ventricle. So you can see that really the main job of the valves is to prevent backflow, okay? So after the blood goes out to the lungs and replenishes its supply of oxygen and gets rid of waste products like carbon dioxide, the blood enters the pulmonary veins and returns to the heart through the left atrium. So now it comes back from the lungs, comes back over here into the left atrium. Similar thing is going to happen when the left atrium is full. It's going to contract, forcing the mitral or bicuspid valve open, and blood is pumped into the left ventricle. When the left ventricle is full, mitral valve closes to prevent that backflow. The ventricle then contracts, forcing the aortic valve open, allowing blood flow to flow into the aorta, and there the oxygenated blood is going to be distributed to all the organs and tissues in the body. So you can see deoxygenated blood comes into the right side of the heart, okay, goes out to the lungs, gets oxygen, comes back in to the right side of the heart, and then is pumped out via the aorta to the rest of the body. So let's watch an animation on this.
Blood flow through the heart. The heart has 4 chambers, 2 upper chambers, the right and left atria, and 2 lower, larger chambers, the right and left ventricles. When both atria contract, both ventricles are relaxing, and when both atria relax, both ventricles are contracting. When the chambers of the heart relax, they fill with blood. Valves between the atria and the ventricles and vessels close tightly to prevent backflow of blood. When the ventricles of the heart contract, blood is forced out of the heart into vessels. The heart is a 2-sided pump, right and left sides, that is continually receiving blood and pumping blood out. The right side of the heart receives deoxygenated blood from all parts of the body through the superior and inferior vena cava. The heart receives the blood into the right atrium. When the atria contract, the blood is forced through the tricuspid valve into the right ventricle. When the right ventricle contracts, the blood is pushed up into the right and left pulmonary arteries through the pulmonary valve to the lungs for oxygenation. Following oxygenation in the lungs, the blood returns to the left side of the heart through the right and left pulmonary veins into the left atrium. When the left atrium contracts, the blood is forced through the mitral or bicuspid valve into the left ventricle. From the left ventricle, it goes through the aortic valve into the aorta and goes to all parts of the body. Remember the heart's set of 4s, 4 chambers, right and left atria, right and left ventricles. 4 valves, tricuspid, mitral, pulmonary, and aortic. 4 major vessels, vena cava, aorta, pulmonary arteries, pulmonary veins.
So hopefully that makes a little bit more sense to you as you watch it while you're hearing it. I think that's the great thing of the animations, is that you can really see it happening while somebody is explaining it to you. So that's one major piece of the heart is blood flow. The next piece is coronary circulation. So we have, not only is the heart's responsibility to get oxygenated blood out to the organs and tissues, it also has to get oxygenated blood to itself. So how does that happen? That happens through its own vascular system called coronary circulation. The coronary arteries deliver oxygenated blood to the myocardium, okay, and the cardiac veins collect deoxygenated blood. The right and left coronary arteries arise from the ascending aorta, so they come off of that main vessel, okay? The right and left coronary arteries supply almost all of the heart with blood. I'm not going to make you, memorize all the different areas that it goes. What happens after the blood goes to the heart tissue, it then becomes deoxygenated, okay, and it empties into the cardiac veins, which then empty into the coronary sinus, okay? That returns blood to the right atrium, okay? So coronary arteries receive blood when ventricles relax, okay? And just another thing to note is that because the left ventricle performs most of the work of the heart, it receives the greatest amount of blood flow. So also, this is when we're going to talk about blood clots or heart attacks or things like that. We talk about the heart not getting enough oxygen, enough oxygenated blood. We're going to talk about these coronary arteries and these coronary vessels. That's where that happens, okay? And once that piece of that heart doesn't get enough oxygenated blood, it's going to die. It's not going to function appropriately. So that's something that you'll talk about more in second semester. The next major part of the heart is cardiac conduction. So there's really an electrical system that is involved in the heart as well, and that's what actually allows the heart to contract spontaneously, okay, and to have it beat kind of regularly. It has some rhythmicity to it, so it should be pumping very regularly, okay, and that's what you're feeling when you're feeling somebody's heart rate. So if it's not pumping regularly, you're gonna feel an irregular pulse. So what's happening at all these different areas, 1, 2, 3, 4, 5, and 6? You do need to know these different steps, okay? There's these special pacemaker type cells that actually allow this conduction to happen. And these electrical impulses really need to follow a specific route through the myocardium for the heart to beat and pump effectively. Okay, so and number 1 there is the SA node, and that's where normal cardiac impulses arise from. An intraatrial bundle of conducting fibers, number 2 there, rapidly conducts the impulses to the left atrium, and both atria begin to contract, okay? When the impulses enter the AV node, number 3, it slows considerably to allow the atrium time to contract completely and the ventricles to fill with blood. So we have to have a little bit of a delay there to allow that to happen, okay? This is where the heart skeleton comes into play and insulates the ventricles, ensuring that only the impulses passing through the AV node can enter. Sometimes we get erratic electrical conduction through the heart, and it causes the heart to beat erratically. We try to limit that, and that's part of the heart skeleton. That's part of that job. So number 4, after passing through the AV node, the impulse picks up speed. It then travels down the bundle of His, okay, also called the AV bundle. Number 5, the AV bundle branches into right and left bundle branches. And then number 6, the Purkinje fibers conduct the impulses throughout the muscle of both ventricles, causing them to contract almost simultaneously. So this is happening every time the heart beats. Okay, this isn't like this is a really slow process. This is happening every time the heart beats. These electrical impulses are moving from 1 all the way to 6. Okay, so you do need to know these steps. Okay, the SA node, which is the primary pacemaker of the heart, fires at 60 to 80 beats per minute. If it fails, the AV node takes over with a firing rate of 40 to 60 beats per minute. And if that fails, the Purkinje fibers can initiate impulses, but really at only 20 to 40 beats a minute. So it's not going to be very effective. We want our SA node really right up there at number 1 to be initiating all of these electrical impulses in the heart and making it, beat with that rhythmicity and that regularity that our body likes the best. So an electrocardiogram is a way that we actually see these electrical currents spread through the tissue. And this is when we put electrodes on the body surfaces, we can record these signals, and that's called an electrocardiogram or an ECG. You guys will do a lab on this and get to do this and learn how to do this on each other. You do not need to memorize all the things that happen in here. You will get some more information on this in second semester, and Miss Levante may want you to do that. But for the time being, I don't want you to memorize everything that's happening here. Just in a general sense, know that an ECG records the electrical activity It doesn't record the heart's contractions. It just is the electrical activity, okay? So when it appears normal, we call it normal sinus rhythm. And if it's irregular, we call it an arrhythmia. So I'm going to tell you what each of these mean. But again, like I said, you don't have to commit these to memory. The P wave represents atrial depolarization, so the transmission of the electrical impulses from the SA node through the atria. This occurs right before the atria contract. The PR interval represents the time it takes for the cardiac impulses to travel from the atria to the ventricles. The QRS complex represents ventricular depolarization, it's just the spread of the electrical impulses throughout the ventricles. The ST segment represents the end of ventricular depolarization and the beginning of ventricle repolarization. Okay, and the T wave represents that ventricular repolarization. So we get atriums contracting. Okay, this is the little time, okay, before allowing the ventricles to fill. We get ventricular contraction and then we get repolarization. Remember, when we talked about the nervous system, we talked about repolarization, and these neurons have to repolarize before another stimulus can come through. So that's what's happening there with the T wave. Okay, so let's combine all of this a little bit in what we call the cardiac, okay, cycle. So the cardiac cycle is a series of events from the beginning of one heartbeat to the beginning of the next. It consists of systole, which is contraction, and diastole, okay, or diastole is relaxation. So in phase 1, and you guys can follow along in your book if you want to see some pictures here to go along with this. On page 276, okay, this shows you the different steps and also shows you this in relation to the ECG or the electrocardiogram. So phase 1, we have passive ventricular filling, okay? Returning blood fills the atriums, pressure increases, the AV valve opens, blood flows from the ventricular into the ventricles, The P wave appears on the electrocardium, marking the end of atrial depolarization. Okay, so we're getting blood flow passively filling from the atriums to the ventricle, and then all of a sudden we get the atriums contracting here in phase 2, ejecting that remaining blood. We call that the atrial kick. Okay, it's really the atriums pushing any last blood they might have in them into the ventricles, because we want each beat of the heart or each contraction of the heart to be effective. Okay, so in phase 2 we have atrial systole. Okay, so the AV valves are open, semilunar valves are closed, the atria contract, ejecting the rest of the blood from the atriums into the ventricles. The ventricles are nice and relaxed here and are filling. Okay, the right and left ventricles receive about 70% of their blood passively, and then the atrial kick happens. In phase 3, we get the ventricles beginning to contract. The semilunar valves are still closed though, so we get increased amount of pressure. We get an R wave appearing on the EKG, okay, and the first heart sound can be heard here, okay. This is, the isovolumetric is the part of the phase. Iso means equal and volumetric means volume. So therefore, isovolumetric refers to something having the same volume or equal volume. The volume of blood remains unchanged here. Pressure rises because the ventricles are beginning to contract, but they have yet to contract. Okay. Phase 4 is ventricular ejection. So the semilunar valves open, blood spurts out of each ventricle, and then we get a tiny little bit of blood remaining, which is called residual volume. And the T waves occur as peak ventricular pressure occurs, and we get the repolarization after contraction. Phase 5 occurs before AV valves open and after the semilunar valves have closed. So we have the pressure in the ventricles has decreased. Okay, the ventricles are relaxing. Okay, the T wave ends on the electrocardiogram as repolarization finishes, and we get the second heart sound here. So S1 and S2 are the two biggest heart sounds that you may hear when you're listening to the chest. And that's, again, happening because of valves closing. Let's watch the animation on this.
The series of events that occur from the beginning of one heartbeat to the beginning of the next is called the cardiac cycle. Here's what happens during one cardiac cycle. In the first step of the cardiac cycle, venous blood returns to the heart and fills the atria. As it does, pressure in the atria rises above that in the ventricles. This causes the atrioventricular valves to open and blood flows into the ventricles. This period is called passive ventricular filling. Atrial systole then occurs. In this phase, the atria contract to eject their remaining volume of blood to the relaxed ventricles. At this point, the atrioventricular valves are open and the semilunar valves are closed. Following is isovolumetric contraction, a brief period during which the ventricles are beginning to contract, but the semilunar valves haven't yet opened. The volume of blood in the ventricles remains constant, but the pressure rises rapidly as the ventricles begin to contract. When the pressure in the ventricles exceeds the pressure in the pulmonary artery and aorta, the semilunar valves open and the phase of ventricular ejection begins. The blood spurts out of each ventricle, rapidly at first and then more slowly as the pressure drops. The ventricles don't eject all of their blood. The blood remaining in the ventricles at the end of the ejection period is the residual volume. At the end of ventricular ejection, a brief period occurs during which both the atrioventricular and semilunar valves are closed. Specifically, the semilunar valves have closed to prevent blood from re-entering the ventricles, but the atrioventricular valves have not yet opened. In this phase, called isovolumetric ventricular relaxation, the volume of blood in the ventricles remains unchanged, but the pressure declines dramatically as the ventricles relax.
So again, just another overview, to hopefully help you understand what's really happening here. Lots to, think about and go through in this chapter. The rest of this is going to be, a little less concept-based and a little more kind of straight memorization of some different terms and things. Cardiac output is a term we use frequently when talking about a patient's cardiac status. So it's important that we understand what cardiac output really means. And if you wanted to figure out somebody's cardiac output, you need heart rate. Okay, so the amount of times the heart beats in 1 minute times the stroke volume, which is the amount of blood ejected with each heartbeat. You would multiply those things and you would get cardiac output. The actual definition of cardiac output, however, is the amount of blood a heart pumps in 1 minute. Okay, so that's why you multiply those two things. Average resting cardiac output is between 5 and 6 liters per minute. We only have about 4 to 5 liters of blood, so you can see that we pump almost our entire circulation of blood in 1 minute, which I think is just quite amazing. There are a few ways that cardiac output can be changed. So both of those are going to relate to either heart rate or stroke volume. So if you see this picture, you can see this picture maybe a little bit better in your book too. It talks about the cardiac center, which is located in the medulla, okay, in the brain stem. And we have an acceleratory center and an inhibitory center. So factors such as exercise and stress stimulate the acceleratory center. The acceleratory center sends out impulses to the sympathetic nervous system, which we just learned about, right? Fight or flight. The sympathetic nervous system sends impulses through cardiac nerves, which secrete norepinephrine to the SA node, the AV node, and the myocardium. The accelerated heart rate, this accelerates the heart rate and increases the force of contractions, right? That was one of the things that the sympathetic nervous system does, increase heart rates. Hopefully you remember that, and this won't be hard for us to remember now. The inhibitory center, okay, does the opposite, really. Factors such as rise in blood pressure stimulate the inhibitory center. The inhibitory center sends signals to the parasympathetic nervous system, the rest and digest system. Okay, this sends signals to the vagus nerve, to the SA node, the AV node, and then that slows the heart rate. Okay, so think about situations where your heart rate would be elevated versus where your heart rate would be slowed. Most people's heart rates are, 60 to 80. Anything less than 60 is what we call bradycardia. Okay, and anything greater than 100 beats per minute is tachycardia. So another couple of terms we need to know. So how do we get input to the cardiac center, and how does the cardiac center know what's going on in the body. So it receives input from multiple different sources. We have proprioceptors, signals changes in physical activity, allowing the heart to increase output before muscles demand more blood flow, so exercise. Then we have baroreceptors or pressure receptors, and they detect pressure, okay, blood pressure. If blood pressure falls, the cardiac output decreases. The cardioacceleratory center then stimulates the heart to beat faster to maintain cardiac output, right? Heart rate and stroke volume. So if the pressure goes down, and the cardiac output's going to go down because of that, we're going to increase heart rate to compensate and pull that cardiac output back up. Then we have chemoreceptors. They detect increases in carbon dioxide, decreases in oxygen, and decreases in pH of the blood. And it again allows the heart rate to be increased, or the stroke volume to increase, to circulate more oxygen and get rid of more carbon dioxide. So 3 different ways that our body knows what's going on throughout the body, and how can the heart beat better, more efficiently? How can we increase stroke volume? Those things to maintain cardiac output. We really want to maintain that normal amount of cardiac output. So then there's factors that affect stroke volume: preload, contractility, and afterload. These concepts can be a little bit confusing. Okay, if you look on page 280, it talks through the 3 different. We're going to talk through them briefly here, and we're going to watch an animation to hopefully solidify some of that information. So preload is the amount of tension or stretch in the ventricular muscle just before it contracts. So it's full, okay? We get a lot of tension or stretch there. The more blood entering the heart, the more the ventricle stretches, okay? So the more blood, more stretch, more preload, okay? Before those ventricles contract and eject the blood. Contractility is the force with which the ventricular ejection occurs. So how strongly do those ventricles contract to eject that blood out of them? We certainly want this to, happen fairly efficiently, okay? Because we don't want the ventricles contracting and not pushing out too much blood. We're not going to get very good cardiac output if that happens, okay? Afterload is the last concept there, and this is the forces that the heart must work against, okay, such as the pressure of the blood in the arteries. So it has to work against this pressure to eject its volume of blood, okay? So an increase in afterload equals a decreased stroke volume, because it's working too hard to push against those factors that, are trying to prevent it from forcing its blood out. So we're going to decrease stroke volume because it's not going to be able to get out as much blood as it wants to. So all of those things are going to affect that. So let's watch one last animation here, and then we'll wrap up this podcast.
The amount of blood ejected by the heart, called stroke volume, is affected by 3 factors: preload, contractility, and afterload. Preload is the amount of tension or stretch in the ventricular muscle just before it contracts. The more blood entering the heart, the more the ventricle stretches. Contractility is the force with which ventricular ejection occurs. The more the ventricle is stretched within limits, the more forcefully it will contract. This is known as Starling's law of the heart. The amount of blood in the ventricle at the end of diastole determines how much the ventricle is stretched. The more blood returned to the heart each minute, the more forcefully it will contract. However, too much blood can overstretch the heart's muscle, causing it to lose elasticity. The forces the heart must work against to eject its volume of blood are called the afterload. Such forces include the pressure of the blood in the arteries. An increase in afterload, such as high blood pressure, opposes the ejection of blood from the ventricles, which decreases stroke volume.
So 3 different terms that you need to know, but remember, they all affect stroke volume. So we talked about the factors that affect heart rate, and then we just talked about factors that affect stroke volume.